rectal carcinoid tumor. Its physical deception starts with its origin point. This tumor typically remains in the submucous coat, the layer of tissue just beneath the rectal lining. Because the growth happens in this deeper layer, the mucous membrane directly over it remains completely intact. When viewed through an endoscope, it doesn't look like an aggressive mass. It appears only as a small, plaque-like elevation on an otherwise healthy-looking wall. This anatomical camouflage is the first hurdle in diagnosis. The physical presentation of the tumor actively downplays the reality of what is developing below the surface. The tumor's behavior initially seems to match its unassuming outward appearance. The majority of these growths are slow in their progression. They are also noted for being very late to metastasize or spread to other regions of the body. Usually, a small, localized anomaly that grows at a glacial pace might suggest a conservative approach, monitoring the growth rather than intervening. Yet medical guidelines for these tumors deviate from that logic, calling for immediate surgical excision even when the growth appears minor. The reason for this urgency is found in the clinical data regarding the risk of malignancy. To understand the threat level, physicians compare the rectal variant to carcinoids in other parts of the digestive tract. It is consistently found to be more malignant than carcinoids of the appendix. This chart shows how the rectal variant sits between the less aggressive appendicular carcinoids and the more dangerous ones found in the small intestine. This places the malignancy rate for the rectal variant at approximately 10%. A 1 in 10 chance of cancer in an anomaly that masks its growth changes the medical math. It shifts the protocol from observation to physical extraction. Because the threat is buried beneath an intact surface, surgeons use specialized localized techniques like endoscopic mucosal resection to reach it. Look at panels A and C showing the deceptive elevation of the tumor. To remove the risk, the surgeon excavates the submucosal space, seen in panels D and E. Finally, the site is secured with metallic surgical clips, shown in panel F. This physical unearthing is the only way to neutralize the 10% threat before it can exploit its hidden position to grow undetected. While effective, this localized endoscopic removal is primarily used for smaller, early-stage discoveries. If the tumor is not caught early, it can become more deeply entrenched in the surrounding anatomy. In these much more advanced clinical cases, the strict medical requirement shifts to a full excision of the rectum. The escalation from a small clip to a full excision illustrates the persistence of this specific tumor if left to develop. There is also the scenario where the tumor is discovered only after it has achieved a late-stage metastasis. In many other forms of cancer, systemic spread might lead a doctor to move away from aggressive local surgery. But here, the clinical directive is clear. Even in the presence of metastases, resection prolongs life. Whether used for an early cure or to extend life in advanced stages, surgical removal remains the primary tool for managing the risk this hidden threat presents.
This cross-section illustrates the healthy anatomy of the human natal cleft. Visible layers include the epidermis, dermis, and subcutaneous tissue, vascular structures. The embedded hair now acts as a foreign body. The body initiates an inflammatory response, causing blood vessels to dilate. Trapped bacteria begin to multiply as immune cells
When you sit for prolonged periods, simple downward friction forces the hair on your lower back to bend and eventually snap under the weight. These loose, broken hairs collect and travel down the intergluteal cleft, the vertical groove between the buttocks. This mechanical accumulation was so prevalent among World War II military personnel bouncing on hard vehicle seats, it earned the clinical nickname Jeep disease. Trapped in that narrow, friction-heavy furrow, the sharp end of the broken hair physically pierces the softened, moistened skin or slips directly into the open mouth of a sweat gland. Looking at this cross-section of the skin, you can see the core mechanical failure at play. The intermittent pressure of sitting and walking acts as a biological vacuum. Every movement creates negative pressure that sucks more loose hair, debris, and skin cells downward into this new pit. Deep in the subcutaneous tissue, that single pit multiplies into a complex network of branching side channels. The immune system reacts, deploying specialized foreign body giant cells to try and digest the trapped hair, but they fail against the dense keratin structure. This creates an expanding underground trap filled with decaying matter. It lacks the internal architecture to heal itself, guaranteeing the defect will grow until it is mechanically dismantled. Patients typically first notice a small swelling near their tailbone. As the trapped debris accumulates and becomes infected, that small pimple quickly progresses into a highly painful 2 by 2 centimeter abscess. The localized infection causes the surrounding tissue to swell and turn red. Eventually, the pressure forces a blood-stained, foul-smelling discharge to surface, often carving secondary drainage openings directly through the skin. While this happens most frequently on the lower back, this mechanical trap forms anywhere friction forces loose hair into skin crevices. Men's barbers routinely develop identical sinus tracts in the soft interdigital webs between their fingers from customer hair. Because the disease builds a self-sustaining, branching network of decaying matter, a successful cure requires surgeons to locate and completely eradicate every inch of that hidden underground architecture. The first mandate of surgical intervention is visibility. Surgeons must find the invisible ramifications of the sinus to ensure no infected tissue is left behind. In this top-down diagram, we see the diagnostic mapping phase. By flooding the main pit with methylene blue dye, surgeons stain the entire underground network, forcing previously unseen side channels to reveal themselves. With the tracks mapped, the traditional open excision begins. Surgeons carve a wide ellipse completely around the dyed tissue, cutting vertically down to the fascia covering the sacrum bone, removing the entire infected mass in one piece. Attempting to pull the edges of this massive void together and suture it shut creates intense physical tension on the skin, which consistently forces the wound to tear open and the disease to recur. To prevent that tension, surgeons leave the wound wide open. They pack the exposed cavity with petroleum jelly gauze, forcing the body to heal from the inside out through 4 weeks of intense, daily dressing changes. Traditional wide excision achieves total disease eradication, but it requires destroying massive amounts of healthy collateral tissue and subjects the patient to a grueling physical recovery. When an abscess is exceptionally massive, or the disease repeatedly returns after prior surgeries, leaving the wound open becomes a severe biological risk. Plastic surgeons solve this using geometry. This diagram illustrates a tissue plane where surgeons deliberately carve the infected zone into a precise diamond-shaped tissue defect, leaving a specific pattern of adjacent healthy skin intact. They perform a rhomboid flap repair. By cutting and rotating that exact mathematically outlined flap of skin into the void, the design closes the wound and distributes the physical tension forces equally across all 4 planes. Surgeons treat severe, recurrent pilonidal disease as a structural engineering problem. They bypass the natural tension limits of human skin by shifting the mechanical load. Today, patients have a minimally invasive alternative that avoids large-scale tissue removal entirely, operating through a single 1 centimeter incision. Working through this micro-incision, surgeons manually extract all the trapped hair and debris, completely clearing the internal cavity while leaving the tunnel walls intact. They insert a precise 1470 nanometer diode laser into the empty tracts. As the glowing fiber optic tip slowly retracts, it physically burns and ablates the infected superior and inferior tracts from the inside out. Surgical methodology has moved from brute force anatomical excavation to precise thermal targeting. The laser destroys the infected lining while perfectly preserving the surrounding healthy tissue. The recovery outcomes between these methods are drastic. Traditional open surgery demands a month of agonizing bed rest. Laser ablation allows for same-day discharge and requires only a basic 5-minute betadine dressing. Regardless of how precisely the surgeon operates, one vulnerability remains. If a new, loose hair grows and falls into the fresh healing wound, the entire disease cycle instantly restarts. To protect the surgical site, patients must adhere to strict post-operative hygiene, including meticulous and continuous hair removal around the lower back until the area is completely sealed. Medical engineering has mapped the defect, calculated the tension loads, and developed lasers to vaporize the infection. Yet the ultimate cure relies heavily on the patient enforcing behavioral changes so the mechanical forces of friction and loose hair never trap them again.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.